Thank you. Thanks very much. And thanks for inviting me. Oh, will it work better? Okay. That's wonderful feedback. Right. Good morning. And yeah, I just wanted to say the Trials Network initiatives from the college have been a spectacular success and would have failed the pub test with me if you'd asked me, is this going to work? I'd have said, no chance. But been proved completely wrong. And particularly the trainee collaboratives have really heartened me and made me feel there is hope. Anyway, I'm going to talk about the ideal collaboration, and I hope by the end you'll understand what that is and why it's relevant to you. Could we just take a straw poll to start with? Who's heard of it? All right, there's a sprinkling. Good. Okay, so there'll be a lot more by the end of the next 20 minutes or so. So I'm going to start with the why, really. This all started quite a few years ago when the reputation of surgeons for not doing trials was so bad that the Lancet actually wrote an editorial laughing at us called Surgical Research or Comic Opera. And that was because of our lamentable performance in terms of doing big trials, doing good trials, or in fact doing any trials. And there's some old statistics on that, but things haven't changed that much. And we were a bit anguished about it, and various eminent professors of surgery wrote in angry letters to the Lancet. But in groups, we bemoaned the fact that randomized trials are more difficult in surgery. Now, I think that's a lot better appreciated by non-surgeons than it was. They thought it was just you, the surgeons. And there is an element of truth to that as well. But it led to a bit of soul searching and a bit of discussion. Why is this so hard? So this is the classical model for developing therapy evidence, and it's based on pharmacology. It's based on drug treatment. You start with the theory, then you have the lab demonstration, animal studies, first-in-man studies, toxicity studies, efficacy studies, and then a randomized trial, and then you do post-marketing surveillance. And it's lovely, isn't it? And this is the surgical alternative. So we have an idea, then we have an animal bench trial perhaps, then we do a first-in-man, and then we publish our outcome experience as a case series, CS. And then what happens? Well, we do some more, and we publish another case series. And some other people take it up and they publish their own case series, and some of them say, I can do it better than you, and others say, this is a rubbish operation, don't do it. And what do you get at the end of 10 years? Do you get a randomized trial? No. Usually you get two opposing camps, or several opposing camps, all shouting at each other, and no evidence to speak of. That's the truth, isn't it? That's the way it's worked historically. So why is that? I got involved with this thing called the Balliol collaboration, which was a sort of wise group of people sitting around thinking about it for a time in Balliol College, which was very nice. And we came to a few conclusions about what's the real-life format for developing innovation in surgery. So one of the things we decided pretty early was this lovely pharmacology-based pattern really doesn't fit for surgery. And so we developed this thing called the ideal framework. And this is where the name comes from. And we proposed some recommendations based on the framework. So what are the problems we identified? Again, these are, you may want to argue about these, happy to do that afterwards, but this was the basic consensus of the things that really are a problem. There are a lot of things that surgeons think of as problems in trials. Like, for instance, all my patients are different. Well, I'm sorry, heart failure patients don't come out of a box or a factory either. They're all different too. But these are the ones where we genuinely have different problems from physicians doing drug trials. When you start doing a new procedure, you have to do a bit of tinkering, you have to modify it a bit, and you don't do that on the basis of analysing 100 cases statistically, you do it on the basis of the one that you did yesterday. So this we call tinkering. And you can't do a randomised trial to an unstable operation that's going to change again tomorrow. So there's a problem. We have to learn new operations, even if you're an experienced consultant. There's lots and lots of papers. I've got a drawer full of them showing that the average is about 25. You have to do about 25 procedures to get up to 80% of your final performance level. And that's going to mess with the trial, because if you're trying to do a randomized trial of an operation you don't know how to do versus one you do know how to do, well, guess what? It's going to introduce massive bias. Operations are more difficult to define than drugs. People always do operations slightly differently. So that can be a problem. And surgeons are very keen on saying, well, we do it well, you don't. How do you define quality control? And how do you define standard outcome measures? But this is probably the big one, and you all know this. we as clinicians have very strong preferences because we're very bound up with the outcomes of the treatment we do. And that makes it very hard for us to keep a very sensible, logical head on. This is the ideal framework in detail. And you can see why it's called ideal, IDEAL, but these are the stages in the development of a surgical treatment. And you just look across them, it kind of makes sense. You start with an idea, you do some, then you have this tinkering phase. Then you have a phase where more people are taking it up, but they're learning, so learning curves are getting in the way. And being surgeons, they're arguing. They're saying, no, no, this is how you do it. No, that's how you do it. No, you should do it to these people. No, you should do those people. This is the phase at which surgical trials usually get aborted. You can't reach consensus. If we can, then we go and do a randomized trial, but we have problems with that because of lack of equipoise, and then we do long-term surveillance. So I just want to take you through a couple of examples from this year to make sure that you've got it in terms of this, because actually this is quite easy. Nice little thing I can flip back and forward. So I'm an upper GI cancer surgeon by background, so I've got mags and journals lying around the house based on this, and I just picked 3 studies last night at random. Laparoscopy-assisted transvaginal resection of sigmoid cancer. I'm sure nobody in the room is particularly interested in that, but all I can tell you about it is it was a study of 21 patients over 2 years in one centre. Now, where is that? Who's going to tell me? Where is that technique on the ideal framework? It's a 2A, absolutely, it's the development phase. So, Sills appendicectomy, a meta-analysis of 7 randomized controlled trials. Where's that one? Yeah, it's 3/4, isn't it? It's already well into stage 3. It's a silly idea, but it doesn't mean you can't do lots of trials on it. So simple enucleation of T1 renal cancers versus partial nephrectomy, matched pair comparison. Slightly more difficult one. Where's that one? 396 patients in 19 centres. 2B, absolutely. Okay, we're at the stage of arguing with each other about this. It's not a randomised trial. The reason it's not a randomised trial, couldn't get them to randomise, just looked at everything together. So anyway, I want to talk now a wee bit about the recommendations, because most people look at the framework and say, yeah, that makes sense. What we then went on and did was say, well, if that's really how surgical operations develop, we should devise better ways of studying them based on the important questions at each of the stages in that development. So what did we say about them? Well, stage 1, we didn't say much. All we said was if you're going to do something new, you should tell people about it, whether it works out well or not. So the idea was a professional innovations database, which you could send your failed innovations to confidentially if you didn't want the lawyers to get hold of you. And we're currently discussing that with NICE, who think it's a kind of a good idea, but they're a bit worried about it. And we have some hopes that we may get some progress there one day. Then for the development phase, this is the tinkering phase. What we've proposed is something called a prospective development study. What is that? Well, it's a small cohort study. It's a non-randomized study, but the difference from your traditional case series are these. You tell the truth. You tell the whole truth. You tell nothing but the truth. So you give a detailed description of your selection criteria and a technical description, of course, but you account for all the cases, and if you excluded someone, you explain why. And then you give a consecutive account of how people did, so that people can look at the graph and say, well, yeah, things are clearly getting better or worse. And you deal with the tinkering. You deal with the tinkering by putting an arrow in the graph and saying, look, at this point we changed this. Now, you're probably not going to have enough cases to prove anything statistically, but at this stage in the development of science, and this is science just as much as randomized trials are, that's perfectly normal, and nobody who innovates actually makes their development decisions on the basis of statistical significance. So this allows people to follow what you're doing, and more importantly, it doesn't hide what you did wrong. Most case series are done retrospectively, and mostly you polish them up and say, this is the finished technique we ended up with, it's really good, isn't it? And you imply that you did that for all the cases, but you didn't. And if you don't tell people the truth about the mistakes you made, they're going to repeat them. And it reduces reporting bias because you're actually reporting everything. So that sounds great. Where are they? Well, there are very few about at the moment, because Ideal's only a few years old, but they're beginning to be published. This is one I've been helping a couple of surgeons in Bilbao with. They've been doing robotic esophagectomies. This is their whole series of 37 cases. This is all the different techniques they've tried, so they've tried a lot. And these arrows represent things, places where they changed their technique. Now, I've shown the length of stay graph here. If I'd shown them the lymph node graph, you'd have seen a sudden leap here, because this is where they decided that they were now feeling brave enough to do formal lymphadenectomy in the medial spine. So that would have probably been a more informative graph to show you, but it's just to illustrate the value of this additional information. This is another one, recently published in European Urology. This is a chap in America who does robotic kidney transplants. And again, this is a graph showing all his cases. And you can't read these because I nicked it off the PDF, but these are all the little modifications he made along the way. So that's food for thought. What do you do next? Once you've got the operation tinkered with and it's stable, then you move into stage 2B development. And this, as I say, is where most surgical innovations sort of die in the desert and never get to a randomized trial. So we need a bridge. And this we call a prospective exploration study. And this may be relevant in discussions later on, because I've heard some of the ideas you've got, and some of them, I think, probably need one of these. What is it? What's the point? Well, you're all familiar with feasibility studies. Feasibility studies are to find out whether a randomized trial is feasible. This is a feasibility enhancement study. This is designed to make a randomized trial feasible. Because the biggest barrier to randomized trials, you all know, is getting everybody to agree to do one. And so if you let everybody do what they normally do and collect the data for a year or 2 years, or however long it takes you to get a decent sized database, the advantages of that over trying to go straight into a trial are quite significant. It gives you a chance to evaluate the technique prospectively and cooperatively, because you're all putting data into the same database. So you're now definitely talking about apples and apples, not apples and oranges. And you begin to develop, through analysing that together, a definition of the procedure. You're going to get some agreement over, well, this is the operation, and that's pretty similar, so that's the operation, but that's way out there, and that's not part of it. And you get enough data to begin to think about power calculations for a trial. And you get enough data to monitor people's learning curves and decide whether they're ready for a trial. But most importantly, if you look at the data together, you often end up with strong opposing views in surgery, all of this. And if you have a joint database that you've all collected data for, and some surgeon says, I never do this on people under 5'6", and you look at the people under 5'6", and their results are just the same as everybody else's, well, he's got to shut up, hasn't he? So you now develop more consensus about what patients you can do a trial in and what the question can be. So it's a way of trying to sort of lure people gently into doing a trial together. Although you should try and get them to promise in advance that they will if they agree with the results of the analysis. So that sounds an interesting idea. Is that happening? Well, yes, it is. And this is an example. This is a national audit that's going on right now with one of the trainee collaboratives on a complicated diverticular disease. Many of you have done general surgery training jobs. You'll remember that this is chaos. People just do what they think is right. There are umpteen ways of treating these patients. So they're collecting the data in a national audit, but we've been talking to them, and what they would like to do is exactly what I described. At the end of a year or two, let's analyse it, let's see where we can get consensus amongst people about where a trial should be done. This is another one we're involved with. This is on a technique called HIFU, high-intensity focused ultrasound. This is very useful for zapping fibroids. Use that once and they're done. No surgery involved, and it seems very safe. This machine was invented in China. The Chinese have got lots of evidence, and they're at stage 2B. We've got very little, we're still at stage 2A. So what we're starting to do is a prospective kind of PDS here, which is going to lead on to a prospective exploration study. So we'll put data in the common database and decide on the final randomized trial.